In India, cancer is now the second leading cause of death after cardiovascular disease. And between ill-equipped hospitals, delayed detections, dismal doctor-patient ratios, and the skyrocketing cost of treatment, our nation is facing a severe cancer crisis. But amidst all this, a set of highly celebrated female medical oncologists are working tirelessly to reverse the trends. And with that, I welcome you to our special feature, Honoring Women Doctors in Cancer Care, an International Women's Day initiative by the Times of India and Merck. Please allow me to introduce our guest. Lead Medical Oncologist, Apollo Proton Cancer Center, Chennai, Dr. Bhavana Sirohi. Director Medical Oncology and Hemato Oncology, Fortis Group Hospital, Bangalore, and Team Lead Medical Oncology and Hemato Oncology at Vikram Hospital, Bangalore, Dr. Niti Raizada. Head of Department of Medical Oncology and Hematology at Patel Hospital, Jalandhar, Punjab, Dr. Anubha Bhartwar. Now, Dr. Raizada, I'd love to kick off the conversation with you. In light of the global coronavirus pandemic, how has this impacted the detection of diseases such as cancer? Are we perhaps witnessing a surge in the sheer quantity of reported cases, or are the number of reported cases now beginning to subside in your view?
COVID has caused a lot of delay because cancer number has been steady and there has been a 1-year lag when the patients have come, and we see patients with more advanced malignancies. We see patients who have delayed a lot in their diagnosis and therefore are likely to do worse than before. But surprisingly, a trend which we noticed is that for unrelated causes or probably for COVID, they went to the hospital and that's when they were detected of cancer. So we have a mediastinal mass which was detected as lymphoma, or we had a lung lesion which was actually later on detected as lung cancer. So there are both of it. And yes, there is a surge of cancer now. There are a surge of new cancer patients who are coming to the hospital.
Building on that, Dr. Sirohi, given the rising occurrences of cancer, specifically among women patients, younger women, women with no prior family history of the disease, this is a huge cause for concern. What do you believe are the underlying factors in play here?
I think it's not just women, but we are seeing more younger men as well with cancers, say of the breast, of colon. And I think it is to do with our younger population matrix and also a lot of lifestyle factors which are involved. With the urbanization that has happened of rural areas in India, our lifestyles have changed. We've become less active. We become more sedentary. We are eating more of junk food and a lot of other reproductive factors as well, like we are delaying childbirth, and the rush or the need to get back to work sooner means that the ladies are not breastfeeding for a set period of 6 months or 1 year that is recommended. So all of these factors have led to a surge of cancer cases in younger men and women.
And one thing I have to bring up, Dr. Bhartwar, I pose this to you and then to the other two panelists, is this doctor-patient ratio. So I'm told that just 2,000 oncologists are essentially tasked with treating upwards of 10 million cancer patients in India. What do you make of that statistic? It's obviously staggering.
Yes, it is definitely very concerning, especially when we compare our numbers as in regards to the Western country. As you rightly said, in India there are about 2,000 oncologists and fewer number of medical oncologists among that, and the ratio for a cancer doctor oncologist per number of cancer patients in India is somewhere between 1:2,000 or 1:3,000. Whereas in the Western world, it is more like 1:100. So already at the get-go, we can see that our doctors are taxed. The system, the system is already geared to be like heavily burdened. The cost of care in India is expensive. Patients don't have insurance. All these issues come into play, and I think also what happens is, even though the numbers are 1:2,000 or 3,000, but actually that number of patients don't end up getting treatment. This is also a factor. I mean, it is obvious one doctor cannot take care of so many patients. So all of this is very concerning, and as you rightly pointed out, India is facing a cancer crisis, not just in the number of patients, but also how as a system we are geared to handle this. We don't have the infrastructure right now. And that's just patients. That just means doctors, hospitals, the radiation machines, everything. It is. We are not ready to deal with the exploding cancer burden over here right now.
Building on some of the points you've made, Dr. Bhartwar, I now bring you into the conversation, Dr. Raizada. And my question is, how do these doctor-patient ratios compare to our counterparts abroad? And what's the solution to sort of narrow this gap? What are best practices that we can embrace from, medical practices abroad? What are they doing right, and where are we falling short?
As per WHO guidelines, for a general population, we need 1:1500, one doctor for 1,000 population. But in reality, in our country, it is 1 to 1,500. And as Dr. Anuba mentioned, the oncologist number is significantly less. The number of oncologists in the country are definitely not in proportion to what we need. 10% of the entire country population is at risk of getting cancer. And for a population like ours, which is staggeringly high, this number, the overall 10% of that population could be remarkable. And unfortunately, what we notice is that they are disproportionately distributed. The doctors we have are more concentrated in tier 1 city rather than in tier 2 towns, and villages will probably hardly have any specialists. Even the hospital distribution is quite disproportionate. The good centers, the good cancer centers are very well located only in the metros. And we have a lot of patients across country who move in these places, which again adds to the cost for the individual. So when they are moving to another city and they have to stay for a period of 4 to 6 months just for cancer treatment, that adds to the social factors. They have loss of occupation, they have a lot of financial burden which they incur, and they have family which is not with them. So these factors are there. Well, this has to be changed, and there has to be more incentives for patients who are not located in these centers. The people who are not located in the capital should be incentivized. We have to have a more even distribution. There are a lot of states which are like Uttar Pradesh or northeast of India and Bihar, which are not having any good not oncology facility. Cancer patients are still as much because that's overpopulated area, and the doctors are significantly less. So there has to be a thought of effort so that we can evenly distribute hospitals and doctors in these areas as well.
And Dr. Sirohi, let's talk about the elephant in the room, which is sort of the economic burden of treating cancer. It can obviously be financially debilitating for any family. And do you think that is perhaps getting in the way of women stepping forward for both diagnosis and treatment?
So we live in a country, Pooja, where we do not have universal health coverage.
Right.
And healthcare itself and cancer care is even more expensive because, there is most of our patients are diagnosed in late stages. So when cancer is diagnosed late, it is not curable, and the cost of treatment is very high. So most of our families would spend so much money in out-of-pocket expenditure that about 70 to 80% of those families are pushed into what we call catastrophic expenditure or increased financial toxicity into poverty. So the healthcare expenses push a lot of the families into poverty. And I think as a nation, a lot of work is being done by the Indian government in setting up new cancer centers. What Niti said earlier as well, the number of seats for oncologists have been increased in medical colleges all across the country. Tata Medical Host Centers, AIMS. So a lot of work is actually going on. Tata Trusts itself is setting up cancer centers in tier 2 cities in Northeast India. So I think over the next 5 to 10 years, we will see that this will hopefully transform into some form of coverage which increases the population coverage for the population. I agree that a lot of more work needs to be done. If you look at US and UK, I mean, I'll just quote the exact figure. They have 160 oncologists per million. We have one. So we have a medical oncology society. 3 of us are women medical oncologists. The members are 500 of them are 500 medical oncologists are member of the Indian Society of Medical and Pediatric Oncology. 85% are men. So I think lots more needs to be done to increase the coverage for women in oncology in India as well.
And that makes sort of a great segue to my next question, which is to you, Dr. Bhatwar. And a surprising statistic to me was that while over 60% of medical students are female, closer to 20% of the practicing doctors in India are female. So many of these female students who study medicine end up not pursuing it professionally. What do you think are the underlying reasons here? And likewise, what are the solutions? Is part-time opportunities that cater to flexible hours, so on and so forth, are those the sort of infrastructures that hospitals need to be embracing?
The thing that you have to remember is at the time that our medical or professional careers are taking off, that is also the time, that personal life is very active at that point. You're getting married, you're having children, your children are growing up, they need you. So I believe that the biggest reason why a number of women don't end up practicing medicine is because they are unable to have that work-life balance, and somehow they lose themselves in this circle of trying to manage your household and children while at the same time being doing your utmost for your patients. And the second thing also is that maybe because of it is true that I think this is true, and maybe my colleagues on the panel can tell us. Women in the professional world, they are considered a little unstable. When you are getting employed, people already know, okay, she's going to get married, or if she's married, she's going to take time off for children. So your opportunities are already less. Your professional pay or salary will be less, and those things can make it very difficult for your professional career to take off right at the get-go. So those are, I think, the biggest factor for women not going into practicing medicine would be the work-life balance. And if we could somehow figure out a way that we could make everything work well on both fronts, I'm sure that more women will end up continuing their medical career and not just studying medicine and stopping it at that point.
Dr. Raizada, I welcome your views here, to what Dr. Bhatwar has just said. And I'd also have a follow-up question for you, which is, do you think there's sort of this subtext, this unconscious gender bias in the field of medical oncology with respect to promotions, with respect to performance evaluations, recruitment, and even salaries for that matter when it comes to women?
So, as you said, that yes, as a medical student, we have a substantial female population. When you come to masters like MD and MS, it comes to single digit figure. Maybe about 5 to 7% of our colleagues would be women. And when it comes to super specialty practice, it's hardly anybody. So you might have one woman in the entire practice who will be similarly a super specialist. And actually, I personally feel that yes, flexi hours, part-time work, all these are very helpful. But at the end of the day, super specialty practice is a binary system in which you do everything and you put in all inputs, or sometimes your inputs are never enough. So you have to compromise in the sense that if work efforts are not there, then you cannot deliver adequate patient care, which is probably of utmost importance while we are practicing. As far as gender bias is concerned, I may want to say that yes, it would be there at a certain level. But over analyzing that fact will be detrimental, because if anybody is adequately skilled and performing at work, then that's enough for you to get adequate support from the management, from your colleagues, from your patients, and from your friends. So just doing what we are supposed to do is good enough.
Absolutely. And Dr. Sirohi, if I could bring you in here, your comments and thoughts around the current affordability of a medical oncology education. How can we essentially encourage more women to follow in the footsteps of our three panelists here and enjoy the same decorated career and series of accomplishments as the three of you have?
So I think as a community, we have to do more to support women to come into oncology. For me, I think it was very easy because I had amazing family support. So I think family support is very important. So I had a resident, I remember, in Tata Hospital, where she had fantastic, both husband and wife were there, but they had parents who were looking after their child. So, in your career progression, by the time you come to super specialization, you've done 5.5 years of MBBS, you've done your 3 years of MD, then you have to do 3 years of DM, and you may have wasted 1 year doing the exams at both the steps. So, the academic clock and the biologic clock are completely at collision with each other. So yes, there is a time to, be married, there's a time to have children. So I think we have to, as a community, as an oncology community and as a society, I feel, be more supportive of women coming into leadership positions. So males in our society, in our culture, there is a lot of gender prejudice. We know that more so in North India, I feel. So women are seen as homemakers and men as leaders. So one of the first or second jobs I did in Haryana, so the person came and said, I would be called sister most of the time, not doctor. And he would say that, Lalli, I want to see the bigger doctor, the head of department. And I would say, I am the head of department. So, it was a huge surprise to them. So I think that stereotyping within our community has to change. Unless we do that, this is not going to change. You will not see more women coming in for post-graduation unless the family and the society supports them. You have to have flexi hours, flexible education, flexible fellowship programs to allow women to, not maybe complete the DM or MCH in 3 years, maybe in 4 years, maybe, they do 3 days a week. We do have that in UK. I've spent about 2 decades in London, and we do have flexible fellowship programs, and which encourages women to take part in those.
And Dr. Baltwar, if you could perhaps also share anecdotes from your own personal and professional journey, what inspired you to become a medical oncologist, and what were some of the challenges perhaps that you faced along the way?
I think I've been, touch wood, I would say, fairly lucky. Like Dr. Sirohi said, family support is very important. I just have a sister, so we are only 2 girls. There's never been any competition about, the boy doing better or anything like that. My parents they pushed us right at the get-go. Like, they were like, you have to do everything. When I finished my MBBS, I was like, I want to go and study abroad, and my parents were like, go ahead, you can go and study abroad. So then I did my internal medicine in the US, and in the first year, you have to decide if you're going in for a subspecialty and which subspecialty you're going in for. And by that time, I had already been, we have different postings, as you call it, while you're doing your internal medicine. And one of my first postings actually was in the oncology ward, and I was actually debating between cardiology and medical oncology, and then I ended up applying for medical oncology because I felt it was a very good fit for me, and I actually think medical oncology is a very good fit for women.
Dr. Raizada, I'd love to sort of get your take here. What is the most professionally rewarding aspect of your job? And for other women that are perhaps considering pursuing medical oncology, how might you guide them? What words of advice might you have for them?
The reason I thought that oncology was the specialty I want to go is I thought it was research oriented. It was very innovation driven, and there was always something happening. And if you look at it, every week there'll be something new which would come up in our specialty. Every week you have to keep pace with what's happening all the time. And yes, as Anubha said, it is a rewarding specialty, because when you have success, we don't talk about cure when we are dealing with hypertension or diabetes, but we definitely talk about cure when the first patient comes to you. The first interaction will be, is this a curable condition? And when we achieve that, almost 50 to 60% patients are likely to be cured. So when we achieve that, there's a sense of relief of what we have done. And that's definitely the most important and amazing thing. And when that patient brings another patient and says, well, we are confident that things will go right here, that really gives you so much of pleasure. And then, as Anubha said, my professor always used to say that if a patient does not make it, there are about 30-40% patients who may not make it. And when the family goes and thank you while they are going, I think you have done your job well. So.
And Dr. Bathwar, I pose my next question to you, which is essentially that for women over the age of 40, given the rising incidences of ovarian cancer, breast cancer, cervical cancer, what words of advice would you have? How might you guide them with respect to early detection? Do they, within their sort of limited medical knowledge and perhaps even more limited financial means, what can they do? Should they be emphasizing more regular annual checkups? Should they be paying closer attention to self-examinations of the body? What general advice might you have for the woman in her 40s and above?
So I think it's a combination of both. Definitely, we should encourage women to be very self-aware. They need to know their bodies. They need to know their breasts. We should definitely be encouraging, a self-breast exam once a month. And at the same time, I would say that they should also consider starting their annual checkups, because that's where your physician can start talking to you about screening for cancer, especially breast cancer, cervical cancer. Those are very important aspects which perhaps we tend to forget in our busy life. So I would say it's a combination of both: being aware as to your body, not just the breast, but overall, and going to your physician once a year for your annual visits. And the third thing I think is promoting cancer awareness. A lot of people don't know what are the things or signs or symptoms they should be worrying about, and that's where I think that programs such as your World Cancer Day and these become very important, because the more you talk about these are the warning signs of cancer, this is where you really should not be at home, you should go to your physician, you should talk to them. So cancer awareness is extremely important. A lot of people have they have like multiple misconceptions and things like that. We as doctors have to promote this. We have to talk about it, not just to our patients, but I also think that having camps, talking in schools and colleges, all these things are very, very important, because that's where prevention is the key, really.
Well, I think that makes for a wonderful note upon which to close. I have to thank you for sharing a bit of your inspiring journey with us, and we salute you for what you do. And so with that, our special feature, Honoring Women Doctors in Cancer Care, an International Women's Day initiative by the Times of India and Merck, comes to a close. Thanks for watching.